Assalamu alaikum. Our second part of the lecture of the cross-sectional imaging for the clinicians. The uterine lesions. What is the merit of using ultrasound in uterine pathology? That the normal zonal anatomy of the uterus could not be delineated except on MRI, because on CT the uterus appear as one zone. It's not zonal anatomy as we see in MRI. What is the zonal anatomy of the uterus as we used to see on MRI? First, the endometrium. The endometrium is hyperintense signal on T2. As I told you before in the first part of the lecture, that the zonal anatomy is better to be delineated on T2 weighted image. How we can know the T2 weighted image? By the fluid signal in the urinary bladder, in the vertebral canal, and so this is T2. In T2 weighted signal, spin echo signal, we can see very much better the endometrium. The endometrium is hyperintense on T2. And surrounding the endometrium, or the thickness of the endometrium, according we used to see in ultrasound, is it proliferative secretory phase or whatever, we can measure the thickness in the sagittal plane on MRI. And this is the normal signal, because sometimes the endometrial pathology not only thickened endometrium, we found altered signal of the endometrium. So this is the normal endometrium. This is the internal os, and here this is the junctional zone. This junctional zone is corresponding to the subendometrial halo seen on ultrasound. A normal junctional zone is from 5 to 8 millimeter in thickness, but up to 12 millimeter we can give it away. More than 12 millimeter we suspect adenomyosis. The junctional zone is also very important in the assessment of the infiltration by tumor. Is it just stage 1, or it is infiltrating the junctional zone and passing to the myometrium? So this is the normal junctional zone, which is the inner layer of the myometrium. Then come the intermediate layer of the myometrium. Here, this is the intermediate layer, and here this is the arcuate vessels, and not to be missed for adenomyosis. Many of the colleagues, when you found these bright spots, he thought of adenomyosis, but this is not adenomyosis. This is the arcuate vessels that is present between the inner 2/3 of the myometrium and the outer third of the myometrium. So this is the arcuate vessels. Sometimes they appear signal void, means they are black on T2, and sometimes it appears bright like that according to the sequence, according to the stage of the cycle, and so on. This is the normal zonal anatomy of the uterus. Then here came the cervix also. The normal zonal anatomy of the cervix is very important, and very important in diagnosis of early cervical cancer. So we have here the endocervical canal, and we have here the inner stromal zone, which appear hypointense. The mean hypointense mean it's black, hypointense on T2, and the outer zonal anatomy is intermediate signal on T2. Sometimes the endocervical canal is prominent due to the presence of cervicitis, the presence of Nepothian follicles. It's not a problem. The main issue is to see if there is infiltration of the zonal anatomy of the cervix, stromal zonal anatomy of the cervix, or not. And here is the vagina. You have to comment on the vagina in all your studies. This is the normal vagina. Any tubular structure have mucosa. The mucosa is hyperintense on T2, and then the wall is muscular, so it is hypointense on T2. This is the urethra, and this is the inner canal. Then we came to the role. What is the role of MRI in fibroids? We ever now and then see uterine fibroids, too much. one from 3 females you can find a fibroid in it. When to ask for MRI? MRI imaging can assist in the preoperative planning for myomectomy by enabling accurate detection and localization of the individual tumors. Conditions that mimic leiomyomas at physical examination and ultrasound can be characterized with MRI imaging. MRI imaging enables quantitative monitoring of the gonadotropin analog therapy in patients with leiomyomas. If we want to accurately see the change in size, MRI will be better than ultrasound because it is non-operator dependent, so we can measure accurately the MRI. We have more indication nowadays: pre-interventional treatment, pre-embolization, pre-hypho, and pre-radiofrequency ablation. Before we can do MRI for assessment and then follow up after the treatment. This is the typical fibroids, but not all fibroids typical. These are typical uterine fibroids. They are interstitial in location. Here is the endometrium, as we just say. This is the junctional zone, and this is multiple intramural fibroids, some reaching subserous, but no one of them indenting the cavity. This is the cervix. So here we have multiple intramural and subserosal leiomyomas, normal endometrial stripe, normal junctional zone, multiple relatively homogeneous leiomyomas. The typical leiomyoma is low signal intensity on T2. This is the typical fibrous tumor. We say before in the first part of the lecture that any fibrous tumor is low signal on T2. Another case, but here there is indentation of the endometrium, but less than 50% of the fibroid is indenting, so this is interstitial reaching submucous phagotype 3. So here there is a well-circumscribed mass of low signal intensity within the interior uterine body, which distorts the endometrial canal, and the mass has a thin rim of high signal intensity. This is surrounding, and this is a differential point from the focal adenomyosis. They have a thin rim of high signal intensity, means it is a pseudocapsule, and we can differentiate from focal adenomyosis. But not all leiomyomas typical, as I just say. So we have to be oriented that we have many different appearance of leiomyomas on MRI. Ordinary leiomyomas are the benign, that is non-degenerated, but sometimes it is degenerated with cystic degeneration, hemorrhagic degeneration, fatty lipoleiomyoma, hyaline degeneration, myxoid degeneration. Leiomyoma variants in between are mitotically active, and this is the problem here, that sometimes we cannot differentiate. Is it mitotically active fibroid or it is malignant? So the mitotically active are the cellular type, the atypical type, and the stump, smooth muscle tumor of uncertain malignant potential. Smooth muscle tumor of uncertain malignant potential. Leiomyosarcoma, this is frankly malignant. And then we have another entity that are the extrauterine leiomyomas. And this is, sometimes it is a diagnostic dilemma. When it is extrauterine, we are queried to say, is this adnexal ovarian or it is a leiomyoma? So the extrauterine leiomyomas with unusual growth pattern, such as the parasitic leiomyoma, the leiomyomatosis, disseminated peritoneal leiomyomatosis, benign metastasizing leiomyoma, and histologically ordinary or benign myomas, and therefore are not characterized as the leiomyoma variants لأن هم outside the uterus. And this paper is very nice if any one of you want to see the variants of leiomyomas. This is the features, different features of degenerated leiomyoma. I want to just to have you have an idea. Just when I write that it is a cystic or myxoid degeneration, how can I know from the MRI? Just from the different signal intensities seen. So leiomyoma degeneration types or histological subtypes, I state that according to the appearance seen on MRI. طب again, what is the protocol of MRI? That I must do T1 and T2 diffusion and enhancement. Especially if I thought of these histological types, the cellular leiomyoma or leiomyoma, when the clinician told me that I suspect that it may be leiomyosarcoma, so I must give contrast. If you are thinking, if it is just fibroids as we all see by ultrasound and Doppler, then no problem, we can not inject contrast. But if we suspect that it may be malignant, rapid growth on your clinical assessment, so we must do enhancing, early enhancement. Restriction on diffusion also is very important, but sometimes it is benign and with restriction. If there is hemorrhage, for example, red degeneration in fibroid may be restricted on diffusion. So here, this is the different signal intensities. الtypical leiomyoma تبقى hypointense on T1 and hypointense on T2. And so those with hyaline degeneration. In cases of degeneration, بيبقى enhancement very minimal and sometimes not present. Cystic degeneration, sometimes we see it post-interventional procedures like uterine artery embolization. Okay? In myxoid degeneration, بتبقى hyperintense, more hyperintense on T2. So this is with myxoid degeneration of a fibroid. And it takes progressive enhancement. Then we came to the histological subtypes that are queried to be malignant. The cellular leiomyoma, that فيها marked enhancement, and sometimes we could not differentiate from leiomyosarcoma on imaging. اللايبوليوميوما ما بيبقاش فيها enhancement, بس the typical features انها بتبقى bright signal on T1. It has bright signal on T1. الstump اللي هم potentially malignant smooth muscle tumors of uncertain malignant potential, ده بيبقى heterogeneous with hyperintense areas on T1 heterogeneous with hyperintense areas on T2, and it takes variable enhancement, restriction sometimes restricted and sometimes not, and unfortunately we could not differentiate from the typical leiomyosarcoma on imaging. So this is very important. If you want characterization of the leiomyoma regarding benignity and malignancy, we must do dynamic contrast enhanced MRI. The second common entity, the adenomyosis. The focal adenomyosis, sometimes the focal adenomyosis is more decisive, يعني sometimes we could not differentiate from the leiomyoma. Here, this is a focal adenomyosis mimicking a subserosal fibroid. This is a picture from the literature with bright spots on T2. في mild thickening of the inner of the junctional zone, the thickening of the junctional zone. So this is with adenomyosis. Another case, here we have the uterus is enlarged, it's not normal sized uterus. We have the posterior, this is the normal anterior wall of the uterus, and this is the normal junctional zone. But here, the posterior wall of the uterus show ill-defined lesion. It's not like the myoma. Note here anteriorly there is a fibroid, but posteriorly it is an ill-defined lesion implicating most of the posterior wall of the uterus with bright spots on T2. The typical bright spots, the endometrial glands that is invaginated inside the lesion. So this is focal adenomyosis of the posterior wall of the uterus, and note the difference with the anterior interstitial leiomyoma. And there is here a subserous leiomyoma also. But we have also other features of endometriosis. We have pelvic endometrioma, large pelvic endometrioma reaching to the posterior to the sacrum posteriorly, and it was bright on T1 features of endometriosis. Another case, and this is a nice picture, although it is an old picture of me, but here we can see how the endometrial glands can invaginate inside the junctional zone, and then after that it invaginate inside the wall of the uterus, and this is a focal adenomyosis. Another case, this is a focal adenomyosis, an ill-defined thickening of the anterior wall, ill-defined junctional zone, dark bright T2 spots, again focal adenomyosis. This is an apothian follicle in the cervix here. The second entity, this is regarding the myometrium. This is the two main entities. There is another invasive molar pregnancy. Many had out of the scope of this lecture today. This is regarding the myometrial lesions. Regarding the uterine anomalies, MRI is better for detection of uterine anomalies, especially the complex anomalies. The less complex can be detected by 3D ultrasound. So MRI provides high-resolution image of the uterine cavity, the configuration of the uterus, body and fundus, the ovaries. The MRI has consistently demonstrated high specificity and sensitivity for evaluation of uterine anomalies. MRI has the added advantage of detecting other incidental abnormalities, including dermoid and submucosal leiomyoma. The uterine abnormalities, bicornuate uterus, bicornuate bicolus. This can be didelphys because we have two separate external opening on the cervix, so this is didelphys. Sometimes, frequently, we use bicornuate septate and didelphys as all entities. No, from hysterosalpingiography, don't accept from hysterosalpingiography that one say to you that it is this is bicornuate uterus. No, except if we can inject from two separate openings on the cervix, then we are sure that it is a didelphys uterus. But apart from that, is it bicornuate or complete septate? We cannot say from the hysterosalpingiography. Usually in the hysterosalpingiography, always accept the report that it is a duplicated uterine cavity for assessment by 3D ultrasound or with MRI. So here we have two separate endometrial cavities, two separate cervical canals, and two external os opening posteriorly. So this is not a bicornuate uterus, this is a didelphys uterus. This is a bicornuate uterus. It is injected from one opening on the cervix, opacifying the two horns. But again, we must do MRI or 3D ultrasound. Here on MRI, two separate endometrial horns. And here we can see that there is pelvic kidney. So this is a pelvic kidney, and this is one of the associated findings that we can see. A very important, when you ask for MRI for a case considered to be congenital uterine anomaly, please ask for T1 and T2 abdomen in order to have a look on the urinary system and on the kidneys. Septate, here we use in the long period from long ago to say that if it is acute angle, then it is with septate, but not always like so. So again, from hysterosalpingiography, we don't say septate, we just say duplicated cavity for assessment by 3D ultrasound or hysterosalpingiography or MRI. Also in MRI, we can, you must ask for what it is, partial septate or complete septate, the thickness of the septum. All this you must write in the report in the MRI. So this is a partial thick septum, partial septate. We have to measure the length and the thickness of the septum. another septate, but rather complete. You have to look separately on the cervix to be sure if it is reaching the cervix or not. And then came the MRI for unicornuate uterus. First, you have to assess if it is truly unicornuate or it is a horde from didelphys uterus. The unicornuate uterus is usually banana shaped, as we see on MRI. Here, this is a banana shaped uterus. Why it is banana shaped? Because it is a half uterus. So this is the tapering of the fundus. This is what we call on MRI banana shaped uterus. This is the normal endometrium. Sometimes the unicornuate uterus may be unicornuate by itself, or it may be unicornuate with rudimentary non-canalized horn, or horn with non-communicating horn, well, sometimes we found blood within, or communicating small horn. So we have 4 types of unicornuate uterus, and I have a lecture on this channel on the approach to uterine anomalies. Please, you can hear it. This case, here we have obstructed uterine anomaly. In the obstructed uterine anomaly, MRI is very important, and you always ask the radiologist, he must mention the level of obstruction. Is it just on the perineum or above? The distance from the perineum? The lower part of the vagina, is it canalized or not? And this we can know from the sagittal plane of the uterus. So this is hematometrocolpus due to low transverse vaginal septum. But we not depend only on the level of obstruction. It may be a part of complex anomaly, like the Hurler-Werner syndrome or the Overa syndrome. This is the obstructed right side, but we have another normal horn on the left side, normal zonal anatomy, normal cervix, and double vagina. So we have, this is obstructed hemivagina of didelphys uterus. And this is a syndrome, in the literature they say that is rare, but we see it many times. So this is the normal cervix, and note this is the distended cervix. So we have to know where is the level of obstruction. The possible cause is a transverse vaginal septum or atresia of the vagina or whatever. So we must know the level, the cause, and the associated abnormalities. Is this cyst in the ovary is an endometrioma or not? We have to look on T1. If it is bright on T1, then it is endometrioma, and it is common with the obstructed uterine anomaly. Complications of obstructed anomaly. Another case, here this is hematometrocolpus also. It is bright in T1 with shading effect on T2, as we stated before in the endometriosis. This is the blood signal. Bright, this is the normal blood signal. تبقى bright on T1 وshading effect في T2. Obstruction where? In the upper vagina. Upper transverse vaginal septum, not low transverse vaginal septum as in the other study. And here we can measure the distance from the perineum so that the clinician can know if it is vaginal atresia, the management is different. If it is only transverse vaginal septum, the management is a little bit easier. So we have to mention if the vagina is canalized or not. Please, in all the cases of obstructed anomaly, we must know the state of the vagina and the distance from the perineum. Then we came to other entity very important, which is the endometrial thickening. We are encountered with many causes of endometrial thickening, either in the childbearing age or in the post or perimenopausal age group. In the childbearing age, we have many causes. The most common is the polyp. And I think the polyp we can all diagnose by ultrasound and 4D. No need for MRI. In the polyp, no need for MRI. It has a typical appearance on ultrasound. Hyperplasia. This is also can be diagnosed by ultrasound, except if suspecting neoplasia. Is there neoplasia in this age group? Yes. Tamoxifen intake, there may be hyperplasia, and this is too much in the era of the breast cancer cases, and the pregnancy related. And this is the first entity to think over when I found endometrial thickening in childbearing age. Pregnancy related, including incomplete abortion, gestational trophoblastic disease, ectopic, and endometrial cancer. في البوست والبيريمenopausal age group, the first is the endometrial cancer. Here the endometrial cancer written in the very delayed, but it is present. يعني we should think if we find manifestations regarding it may be malignant, we must do MRI. Gestational trophoblastic disease, and this entity needs MRI in most of cases to know the degree of invasion of the myometrium. This is very important. Also in cases of incomplete abortion, retained products versus ADM, it's a common entity, and I have a lecture on this channel also on the pregnancy related disorders in the childbearing age group. Post and perimenopausal, we have endometrial cancer, endometrial hyperplasia, endometrial polyps, exogenous estrogens, but most of this group we need to do MRI for confirmation. Of course, ultrasound and Doppler is very important, but we have to do MRI if we need confirmation. This is the appearance of endometrial polyp on MRI. It's not specific. Polyp on MRI is not specific. So this is endometrial polyp, the most common pathological lesion of the uterine corpus. This benign nodular protrusion of the endometrial surface that consists of an irregularly distributed endometrial glands and the stroma. This is endometrial polyp. So, is something characteristic for the endometrial polyp from the endometrial cancer? The dynamic contrast enhanced MRI. On dynamic contrast, if it takes early enhancement, it is with polyp. If it takes delayed enhancement, usually the endometrial cancer is poorly vascular, so it does not take contrast as the myometrium. But the polyp can take early contrast enhancement, and this can differentiate between polyp and endometrial cancer in the postmenopausal age group. This is endometrial cancer, very huge uterus. In the endometrial cancer, how to assess? MRI is essential for the preoperative staging of endometrial cancer. It can accurately depict the depth of myometrial invasion, which is the most important morphologic prognostic factor and correlate with the tumor grade. Presence of lymph node metastasis. This is very important. We must look for the lymph nodes. What are the lymph nodes affected in endometrial cancer? The leukoregional lymph nodes, which are the internal iliac and obturator group of lymph nodes, we have to check. Diffusion weighted MRI and dynamic contrast enhanced MRI are very useful adjunct to the morphologic imaging and improve the overall staging accuracy. يبقى الديفيوجن برضو مهم جدا زي ما قلنا في الأوفاريان. برضو الديفيوجن here in the uterine is very important. Sometimes those patients have, for example, creatinine level high. We can not do the dynamic contrast enhanced, but we can depend on the diffusion weighted MRI in these cases. Of course, this is a neoplastic process involving most of the uterine cavity, infiltrating the myometrium, causing pyometra or hematometra. عشان أقول pyometra or hematometria, we must put picture T1. Invading the cervical stroma here also, invading the cervical stroma. And this is the normal cervix, not here. This is the cervical stroma infiltrated. So here it is reaching the cervix. This is very early endometrial cancer. Note here, the endometrium is not markedly thickened, but it is altered signal intensity. There is altered signal intensity, hypointense signal present here with infiltration of the junctional zone. Note here, this is normal junctional zone, but here it is abnormal junctional zone. So this is very important. Early endometrial cancer. Stage 1A. Another case, a very small endometrial lesion here, but it takes enhancement on the post-contrast. So this is very, very early endometrial carcinoma. Staging بقى, we have to put the staging accordingly. This is the altered endometrium. This is not the hyper-intense endometrium we use. This is markedly thickened endometrium with indistinct junctional zone in parts. Here it is protruding to the cervical canal, but it is not بس هنا في برضه invasion للcervical stroma في posterior part. So this is stage 2. Note here in the delayed sequence, the endometrial carcinoma takes faint enhancement, although it is very, very large malignant mass, but it takes faint enhancement in the post-contrast, in the delayed كمان. In the early, you will find it will not take contrast at all. And this is the different staging entity of the endometrial carcinoma. Stage 1, confined to the endometrium or just less than 50% of the myometrial thickness. Stage 2, there is invasion of the cervical stroma, as we seen in the last case. And stage 3A is serosal invasion, 3A. If there is a vaginal or parametrial invasion, so it is 3B. لو في affection للبلادر أو الrectum بقت 4A, not like the ovarian cancer. At the next region, MRI فيه stage 3A. If metastatic to the lymph nodes, if to the pelvic lymph nodes, then it is 3C1. If it is to the para-aortic, then it is stage 3C2. B if the 4B if there is distant metastasis to the liver and otherwise. Take care. Sometimes the distended cavity is not an endometrium. It is just hydrometra or pyometra or hematometra. So you have to differentiate by looking on the different signal. Here, this is the T2, bright signal on T2. But here on T1, it is low signal. And the cervix, في loss of the zonal anatomy. So this is hydrometra due to cervical stenosis post brachytherapy. Okay, and note here there's a fluid level. Note here this is a fluid level denoting that it is just fluid inside the cavity of the uterus, and this is common complication after cervical stenosis post radiotherapy. Regarding the cervix is very important on MRI. The cervical zonal anatomy is very important on MRI. We have just stated in the first part of the lecture. Here, this is the inner layer of high signal intensity, which is the mucosa. And then the fairly wide middle layer of low signal intensity, the inner stromal zone, and the outer intermediate signal stromal zone. Okay. The most common that we fear from is the epithelial tumors of the cervix. We have many pathological entities, but the most common is the squamous cell carcinoma. The squamous cell carcinoma has typical appearance on MRI. In sagittal T2, it is hyper-intense mass arising from the cervix, sometimes engulfing most of the cervix with no zonal anatomy residual part seen. And this is, usually we say that the radiology is pathology in shadows. So if we have an exophytic mass on pathology, it is mimicking that on imaging. This is an endophytic mass. We have the cervical carcinoma, either endophytic or exophytic mass, according to the age of the patient, according to many criteria. So this is a large endophytic mass, loss of the zonal anatomy, hyperintense. It's not like the normal hypointense signal, with entrapped fluid in the uterine cavity. And this is very important in the postmenopausal age. If you found entrapped fluid in the endometrial cavity, you must suspect cervical lesion. We have rare entities like the malignant melanoma. Sometimes we encounter in the cervix, and the MRI can characterize this because malignant melanoma is hyperintense on T1 due to the melanin present inside. We have also the adenoma malignum, and this is very important, adenoma malignum. This is very important to differentiate from the most common, which is the cystic cervicitis. If we found multicystic lesion in the cervix, if you have a solid enhancing component, then you should think of adenoma malignum. But not always you think of adenoma malignum, because the most common is the cystic cervicitis, multiple large cysts in the cervix but with no solid enhancing component. We have other non-epithelial neoplastic lesions can arise from the cervix. If you find a large fleshy mass, you should think of lymphoma. Lymphoma can come everywhere. So this is a large lobulated fleshy mass replacing the cervix. We should think of lymphoma. But we have benign entities like cervical leiomyoma. This is a very large cervical leiomyoma with whirly appearance, displacing the cervical stroma and protruding to the vagina. So this is a leiomyoma. How could I know? It is still, although it is very large in size, but still preserving the cervical wall. It's just displaying the cervical wall on it, but there is no infiltration of the wall as we see in malignant lesion. Staging of cervical carcinoma, very important by MRI. Local staging is very important by MRI. But if it is an overt malignant process with lymph nodes and ascites, then we can do CT. But if you want to know the local extension, you must do MRI. This is stage 2 because it infiltrates the upper vagina. It is infiltrating the upper vagina, so this is stage 2 cervical cancer. Here what we can see, the parametrial infiltration. If we have a look on the MRI film on the axial or coronal plane, we see that the normal hypointense annulus of the cervix is interrupted posteriorly and reaching the the parametrium. So this is how to see the parametrial infiltration. So this is parametrial infiltration. So this is stage 2B. When you find parametrial infiltration, please, you must check for the lymph nodes, because in many cases, if there is parametrial infiltration, you will find lymph nodes at the same site of the parametrial infiltration. And here, parametrial infiltration on the right side, you can see right lymph nodes seen. If it is reaching the lower vagina, then we are 3A. We are stage 3A. Here, this mass is reaching the lower vagina, then this is stage 3A. If it is reaching the pelvic side walls, the pelvic muscles, this is stage 3B. If it is reaching the pelvic muscles, and this is how to see in the axial plane, this is stage 3B. If we have infiltration of the ureters, this is very important. I think this is important question for surgeons, if it is infiltrating the ureters or not. So very important to check the kidneys and to see if it is infiltrating the ureter or not. Here there is ureteral infiltration with obstruction with subsequent hydronephrosis. So this is 3B, stage 3B disease. 4A, if it is infiltrating the adjacent organs, infiltrating بعنف, this is infiltrating the anterior wall of the urinary bladder, في loss of the mucosal layer of the urinary bladder, and the mass is seen infiltrating here in the urinary bladder. And here it is infiltrating the rectum. And here, stage 4B, there is distant metastasis to the liver. So here also there is distant metastasis to the liver. Regarding the lymph node staging, the very large lymph nodes here, internal iliac, very large lymph nodes. And this is the revised FIGO staging for cervical carcinoma from the literature, more detailed than before, and we see many examples on the last slide. Then we came to some entities that better seen by MRI, like the AVM. This is uterine AVM with large arcuate vessels, large feeding arcuate vessels, small fibroid here. So this is the appearance, tubular signal void, the typical appearance of the AVM. Thank you for listening, and hoping to see other lectures on the channel. You will benefit from it, inshallah.